Okay, now why can't I advance the screens? Okay, here we go. So, and here are our learning objectives. So we'll be talking about hopefully potentially better practices for infants with NAS, and we'll be talking about different models of care for the pregnant woman and her infant who have been exposed to substance use. So, as you are aware, there are a lot of systems that are interacting with families affected by substance use disorder. And here we're going to be talking about several of those, going into a little detail, but this is just a snapshot of a few. As you know, we have our healthcare system, our child protective services system, the judicial system, social services, among other things that may that these families may be interacting with or involved in the care and service of these families. So this sort of is a visual that just shows sort of what we're going to be talking about, that here we have an infant diagnosed with NAS, and then all these interacting and overlaying circles of care systems that are touching this family, which creates problems, or there's lots that of enhancements for this, but it also can cause some problems, not only at the family community level, as we're trying to ensure that nobody slips through the cracks, but also at a larger systems area to make sure we're not duplicating or not having something covered. So as to talk about the organization I'm with, the West Virginia Perinatal Partnership, we're a statewide organization concerned with improving health outcomes for moms and babies. We work very closely with healthcare providers around the state, as well as other stakeholders, and as we try to achieve our vision. So, and as part of that vision, we have, ever since the partnership began in 2006, substance use in pregnancy has been identified as one of the major causes of negative health outcomes for moms and babies in our state. So at that time, we had put together a committee to start looking at that issue. The committee's grown not only in the type of folks that participate, but in the number of folks that participate. And out of that committee work, there are a few things that we have done, but one of the biggest things is our Drug-Free Moms and Babies project. This program started in 2011 with funding from the state and the Benedum Foundation, and we were really looking at how to better identify women in pregnancy and also provide the support and care that they need. And to be frank, a lot of that work kind of stemmed from the fact that we were hearing from our OB providers that they knew that there was a problem with substance use, but that they didn't really want to identify women because they weren't quite sure what to do with them if they identified them. So we really looked at, well, what would a model of care look like so that we could really try to intervene as early as possible to ensure a healthy mom and a healthy baby. And since that program started, I think we started enrolling women in 2012 as part of a pilot project. It's really grown up from the original 4 sites to now we're in 17 sites around the state. And I know this is a busy slide, but what it shows is the black diamonds are delivery hospitals in the state of West Virginia. And then the blue stars show where we have a Drug-Free Moms and Babies program. So as you can see, over the years, since we first started this program, we've really grown quite a bit, that we're covering most of our areas of the state now. And this is the model of care. We want to ensure the woman has appropriate prenatal care, postpartum care services, that she is in substance use, being treated for her substance use disorder, whether that's medication-assisted treatment or other, including group and individual counseling and other treatment needs. Her social services needs are being addressed. As you know, a woman doesn't come to us pregnant with a substance use disorder without having a lot of other needs. So whether those are nutritional needs, housing, childcare, transportation, we really are looking to try to ensure that they're linked to our home visitation programs that can also help out in the community, make sure those needs are being met. And then what the Drug-Free Moms and Babies program provided was some outreach, a complete needs assessment, referrals, follow-up, and peer support services. And all of this would not be possible. And what the Drug-Free Moms and Babies program really did was ensure that there was coordination of care or navigation services called different things by our different programs. But there is a designated person right there in the midst of that, linking all of those services together and ensuring that the women's needs are being met. Another thing I just wanted to mention, because it's a new project of our organization, and it's sort of a continuation of our Drug-Free Moms and Babies, is a quality improvement project that we have started in collaboration with the West Virginia Children's Hospital Collaborative. And we're really trying to ensure that for the health and safety of the mother-baby dyad who has been affected by substance use disorder, from when they transition from the inpatient setting, meaning after delivery, back to their home community. So we're the intervention itself for the QI project is ensuring that in the hospital setting that there's education being done with the mom and the families, that the discharge planning is comprehensive in terms of making sure that once the mom and her infant leave the hospital, that they're linked up to appropriate services. So, and that is in 5, where the QI project involves 5 hospitals around the state. And those blue stars show where those are. And the only one that's actually not on there that is participating is UHC there in Bridgeport. So another program that we have collaborated very closely with is Project Watch. Project Watch is responsible for completing the birth score, which is a risk assessment tool that is filled out on every baby born in the state of West Virginia. This gives a little bit about the code and some revisions that were made to the birth score back in 2007. Primarily what I wanted to point out was that the revised instrument allows the state to collect other information beyond just that score to help ensure that infants are identified that may have special needs. So this is the factors that are looked at when completing the birth score. The birth score is filled out upon discharge at the hospital. It can be started prior to discharge. It's typically filled out by a nurse, and a lot of the information comes directly from the medical record. And really what they're trying to do is identify the origin of the tool was identify infants at risk of dying within their first year of life. And those that scored above a 99 were considered high risk and were eligible for more visits. Their pediatrician was notified so that they would get additional eyes watched on them in care. So back in 2016, there were a couple of revisions made to the birth score. In 2016, we had some questions around substance use, intrauterine substance exposure actually, and NAS. added to the birth score. So now we can collect in real time the numbers of babies that have been exposed in utero and those that have been diagnosed with NAS. And this, I've gone through that. It's now a web-based form. The information is collected quickly and in real time. So the Children with Special Healthcare Needs is another program of the Office of Maternal and Child and Family Health that we work closely with. This program, back a few years ago, that had a change that if a child was diagnosed with NAS, they were automatically referred to Children with Special Healthcare Needs to provide case management to those families. And then I think I'm going to turn it over right to Susan here.
Yeah.
Do you want, Susan, do you want to share your screen or do you want me to continue to advance the slides?
Sue's going to do it for me, I think.
Oh, okay. And while Sue's getting that up, I would just mention in terms of the Children with Special Healthcare Needs program, we've not been able to get a lot of data currently on where, how many babies with NAS or how many families with babies with NAS that they're treating, but that is something we at the partnership have tried to have a better understanding of.
Thank you. Thanks for all that great information. It's exciting about all the different systems and how we're working to wrap around these families. All right, well, just as a precursor, it's rainy and yucky here and my internet's being glitchy too, just in case I freeze for a second. It did it once, but I came right back, so. But I wanted to introduce a program that some may be familiar with and some may not. And it kind of comes, it's weird to put it in the slides, but when we're talking about all the different programs that are available to our families, we didn't want to neglect having the opportunity to talk about CASA. So if you're not familiar with CASA, which stands for Court Appointed Special Advocates, it is a program, it's a nationwide program that's been started back in the 70s by a judge who wanted to make sure that he was getting all the facts in abuse and neglect cases and that the best interests of kids were being represented. So this is back before you saw regular use of guardian ad litem, which are the attorneys that represent children. And so you've seen across the country, every state kind of has a different way of handling the people who represent the children's best interests in abuse and neglect cases. But here in West Virginia, we have the best practice model, and that's a partnership between the guardian ad litem and CASA volunteers. So we are a program, my program here, which is Ohio, Marshall, Wetzel, and Tyler counties. We're one of more than 900 programs nationwide. There are 10 programs in West Virginia serving about 31 of those 55 counties. So if you're interested in more information, wvcasa.org can tell you the closest CASA program to your area. So what does CASA do? It's very similar to the guardian ad litem role. Our job is going to be advocating for what happens to the kids who are involved in abuse and neglect cases. But instead of being attorneys, we are recruiting and training and supporting community volunteers. So while my staff is our social workers by our trade and our education, the volunteers that we recruit come from all walks of life. And they might be, a lot of them are educators, nurses. When they go into their retirement, you know, they're looking for a way to give back to the kids that they've seen along their career. And this is what they come to. The next slide. So CASAs are typically appointed into a case from the onset of the judicial proceedings, and then they stay until the child has been reunified or adopted. The volunteers meet with everyone that's involved in that child's life. They are right from the beginning of that initial order, when mom gets an attorney and dad gets an attorney, the children have an attorney appointed to them as well as the CASA program. We provide ultimately information about what we think should happen to the judge and to the rest of the MDT. And then one of the things that we think is special about our volunteers is that when they're typically only assigned to one case at a time, they're able to really just do a really thorough job with their recommendations. And a lot of times they provide really valuable information to the MDT. As we know, our CPS workers have high caseloads and are pulled in multiple directions. And so we help them by providing additional information. Next slide. So one of the programs at our CASA this year is called Impact West Virginia. And so maybe you've heard a little bit about that as we've gone through the scope process. We have an impact program here. Wheeling Hospital has an impact program in Burlington. And it is a pilot program that works with communities to create opportunities to address the needs of children diagnosed with neonatal abstinence syndrome. So the goal is to improve the health and well-being of children, their moms, and we really want to look through this two-generational approach as kind of our catchphrase. So we are working to kind of network and facilitate conversations, whether it's maybe between different providers, the services that are directed to families, helping to coordinate services outside of that impact system. So I'll give you an example. You know, my patient navigator, she's going to work with families with a newborn and help link them to the services that they need within the community, and make sure that, you know, helping mom to follow up. And does she have any questions? Is she having a difficult time getting in with a doctor's appointment? Did she attend the doctor appointment? Just helping link to services. Next slide. So again, the patient navigator, that's what we're calling the employees that work within this grant and the families. They can help link for adult education and employment, transportation, housing, utility, food insecurity. We'll help them if there's domestic violence that's going on, behavioral and mental health, and substance use treatment. I think our patient navigators go above and beyond to help link them to the services that they need. And that warm handoff is so nice to be able to create an opportunity to walk them in the front door of you know, someone who's going to help, you know, figure out a housing situation for them. Next slide. So Impact has really great tools out there for you. They have developed an online clearinghouse for training and resources for families and providers. As I encourage you guys to really go and check out all of the information that they provide. They have social media sites too, where your organization can share the information and the trainings that are coming up, and they have great material out there. You can learn about the best practices and strategies, has resources, checklists, tools, webinars, learning modules. This could be really important information if we keep this, if we end up doing any more work from home, which I'm worried about, but now you'll have plenty of places to go for your training, because this clearinghouse has lots of great opportunities for all that continuing education. Okay, next slide. So we really believe with this whole impact team and everyone that's been putting these trainings together, that it takes a village to wrap around these families. And these are some of the programs that we highlighted today. So Sue, are we ready for the case study? Is that where we're at?
Yeah, I'm gonna pull it up right now.
Great, thank you. All right, so today's case study is a snapshot from our CASA/impact cases. And we're gonna kind of walk through the background information regarding a mom that this is kind of compilation of multiple moms, but it's one of our kind of typical, if we ever want to call something a typical case. So this mom, early in her prenatal care, tested positive for opioids and benzos. She didn't have a prescription for either of the medications. So her doctor referred her to the Drug-Free Moms and Babies program. She enrolled in an MAT program. She was complying minimally with the requirements there. Throughout her pregnancy, there's been several police interactions at her home that involved domestic violence allegations between her and her boyfriend. They alternated in accepting blame for the altercations. No charges were filed for any of the incidences that were going on, but there was definitely situations that police had to come to the house for. In mom's past history, she did have a child several years ago. This child was removed from her care at birth due to drug use. Mom was incarcerated shortly thereafter. She did not participate in the abuse and neglect court process, and her rights were involuntarily terminated. This child was adopted by a relative. At the birth of the new baby, which was approximately a month premature, she tested positive cocaine, Suboxone, THC. She denied having a relapse. She stated that her boyfriend smokes marijuana and she's in the room, so that must be the reason for the positive drug screen. Denied use of cocaine at all. Her boyfriend did show up to the labor and delivery. He was obnoxious to the nurses, appeared to be high, was combative when asked to leave the premises. And then when it was time for the child to be discharged, based on the prior terminations, current safety concerns in the home, the baby testing positive and the problems it was having, CPS petitioned the court for custody. It was granted and the child was placed in the same home as its half sibling. The baby is now 2 months old, is having issues with her sucking reflex, tremors, and tummy issues. So our community discussion questions, we're going to break out, I think, soon to 4 groups, right?
We're going to have 3 today now, Susan.
Okay. Which ones are going to have, do you have them? Because there's 4 questions.
So Ashley's going to do question 1 and 2 for
Okay.
us in her group. And then you and Janine can have 3 and 4.
Great. All right, so we're looking at, we want to look for the systems of support that were provided and the community resources that we could refer mom to, and then also what types of resources would be available to that foster and kinship provider. We've talked a lot about that over the last few weeks, what kind of things they should be looking for and what kind of assistance they might need. And then how do we increase communication across systems of support? Are there policies and laws that create barriers to helping moms and babies? And this kind of just pushes us into thinking, how do we do better? Where, might we, where are we doing well and where can we do better?
Okay, there we go. Okay, Susan, I'm going to turn it back over to you to lead our report out session.
All righty. Well, I think you said Ashley had, did I blip? I'm all right. All right, I think you said Ashley had the first and second questions. So Ashley, you want to tell us?
Let me share my screen real quick because I think. Can you see my screen? Okay. So question 1, kind of the was lacking. My group thought that the Drugs-Free Moms and Babies, the MAT, and the kinship provider was all positive supports, but felt that it was the domestic violence issue was lacking, as well as some of the intervention after the birth to address the continuation of the mom using substances, and there could have been a plan in which the mom could have been involved with the feedings and kind of that bonding process, as well as mental health resources for mom and services for dad. Question 2 was about the community resources that we would connect her with. So the group came up with a pretty long list. First being mental health, some domestic violence counseling for mom and her partner, CASA, birth to 3, of course, West Virginia Impact, drug-free moms and baby. And then for the adoptive parents, providing them with training to deal with a baby diagnosed with NAS. And then making sure that the baby is linked with pediatrician and is attending their well child visits. And we couldn't remember the name of it, but it's a program that Burlington has, that a mom can have inpatient treatment and the baby can go to treatment with her, so they don't have to be separated. And then making sure mom is getting visits with the baby. And then the Happy Project, as well as a Happy Fatherhood Coordinator. And connecting the kinship provider, if it's a grand family, to Healthy Grand Families program, or if it's just a foster parent, to a foster parent support group, and then family treatment court.
Awesome. You guys did a great job, and it's going to really segue nicely into the other groups and talking about family treatment court here in a minute. Who had another group besides me? Did Janine?
Yeah, I did. And so Melinda had agreed to do our.
Yes, I can share ours. There's going to be a
and
lot
I'm
of.
sorry, we didn't write them down. I told her, oh no, we don't have to write them down if you'll just take notes. So I apologize in advance.
Yeah, so I'll just go over the notes we took. There's a lot of overlap with what was just stated. As far as resources, of course, West Virginia Birth to 3, the WIC program. I know in some areas we have the Gabriel Project, which provides clothing, diapers, car seats, cribs, all that kind of thing. Right from the start, Parents as Teachers or My House, some of those home visiting programs. Make sure the family has SNAP benefits, clothing vouchers. Aetna has the case management, like I think families do their well child visits. There's some things that are available there. Foster parent support groups. I guess some of them also give foster families a chance to get together, but also provides CEUs for foster families. And then we also talked about including the biological mom as far as looking at resources for her, maybe a possible higher level of care or residential, or, you know, her concerns and issues. And also encouraging that postpartum visit 2 weeks post-delivery instead of 6, just because a lot can happen in that 6 weeks. So that was pretty much what we had.
Wonderful. Thank you so much. I also did not put it on a slide like Ashley did. Ashley, get the gold star for today. But our group did also talk about some of the resources available, and we had a lot of the same stuff that was discussed in you guys' group. So I'll just go with the last question, which talked about increasing communications across support systems, and then barriers that were there. And so we spent some time kind of talking about how different programs don't always have the contact information for each other. And moms and dads, they don't always know who's coming into their home providing the services. They're not always they're like, I don't know, I have an impact lady, I don't know her name. Let me look it up in my phone, or I think she left her card on the refrigerator. So trying to help get them organized with being able to share the contact information. But we love the idea of like some type of coordinated database where we all could look each other up. Someone says, I'm working with an impact lady, then I can look up the impact person in that county. Some examples, just like say birth to 3 and a home visiting person were working within a family system, they need to coordinate so that they can do good, delivery of services and coordination, and not overlap or tell the parent conflicting information. And then each person has to have a release from their agency, in order to do that. We talked about the fact that, the confidentiality of CPS processes in general sometimes make it hard to know who all is involved. So if you're an agency that's providing services, but you don't necessarily know what's happening in the case. So the court system, they expect that you provide the services and report out what services and how mom's doing or how the baby's doing, but they're not necessarily imparting information back to you about how the case is progressing, what stage we're at, whether this should be a service provided just to the foster mom and baby, or should we include the bio? You're kind of like always just at the mercy of waiting for CPS to tell you what is happening, and what they want you to do. So we heard from a few providers about that. On the medical side, we talked about, how foster homes usually have incomplete information. They usually don't have, medical history. There's incomplete records. So they don't have the information to pass that on to the providers, like the pediatricians and the medical personnel. So sometimes, not knowing the entirety of what you're dealing with can be frustrating to medical providers. Also, the process of getting approval for procedures. So, does bio mom sign off on things? Does foster mom signing off? Do you have to have the CPS worker, sign off on things? How do you get that in a timely manner for different procedures that need to be done? So there are definitely some barriers that exist in our system. Does anyone have anything additional they'd like to add? Well, I thought that this would be a great opportunity to introduce to you guys family treatment court, because great in Ashley's group, they even mentioned it, and in my group, we talked about it as well. And family treatment courts are a best practice model, and we're starting to see them come across the state. So in Ohio County up here in Wheeling, we had one of the first programs. And so we've been up and going over 1.5 years now. And then there's more family treatment courts that are being rolled across the state. And this really is the best practices model for dealing with abuse and neglect cases. So the greatest, honestly, in my 14-year career in abuse and neglect court, this is the most exciting, most awesome thing I have seen. This real true ability to work with families with a goal of reunification and wrapping around of support just is awesome, because so many times we talk to these families and we think that they need to figure out how to access all the things and do all the things and do it right without complaining, without being upset that they're being asked, to drug screen and every day and participate in parenting and have these 1-hour visits a week. And it's a lot. Improvement periods are a lot for our families. Well, in family treatment court, we have a much more supportive environment. We have a coordinator, and I know that one of the things we had talked about as a solution to problems was having a case manager whose job it is to help coordinate all of the different things. And in family treatment court, you have a CPS worker who's dedicated just to family treatment court, and you have a family treatment court coordinator who works under the judge. And the two of those people working together help the case manage a case in the most empowering way for families. And so we have recovery as our first initiative. There's 5 different stages to family treatment court. Each stage that they go through has, a minimum time frame that they, go through, and then they can stay in a milestone for a while if they need more time. But we go through, getting clean first, and then working on adding in goals along the way. So recovery treatment is accessed more quickly. One of the goals is to remain at home throughout the program participation. And this is, that children could actually remain at home we're not there yet in our courts, but I would love to see us get to a place where kids don't have to be removed in order for their parents to get help. We're always going to have cases where kids need to be removed because of safety concerns. But sometimes, you know, if we have intensive wraparound services, can a child actually remain at home without that trauma of removal is a goal. Reunification of that family within 12 months, the goal to decrease repeat maltreatment and decrease re-entry into foster care. Those are all goals of family treatment court. So what they do is they use a team atmosphere, and on the team, you're gonna have from CPS worker to the family treatment court coordinator, you have CASA, the guardian ad litem, you have people from the recovery community. So we have like someone from Northwood that sits on the team, a therapist, someone from the DRC, which is where our drug screens are done. And they also do groups, like relapse prevention groups and things like that. We have someone from the education system, so we can make sure that the child's you know, needs are being met through that. And then our domestic violence shelter and other types of programs, like from jobs and jobs and hope and things like that are included. So we meet every single week. Instead of these cases that sometimes only meet every 90 days, we are just staying on top of these parents on a weekly basis. The team meets every week, and the participants come every other week. So they're actually in front of the judge every other week, just showcasing their progress. So we celebrate their progress and just really provide encouragement along the way. I don't know if anyone has any questions about family treatment court.
Question.
Yeah.
Can you talk a little bit about the difference between drug court and family treatment court?
Yeah, they're actually very similar. The model is very similar, but family treatment court is going to be an abuse and neglect case, not a pending drug charge. So like, here's an example. We have a mom who her CPS case started based off of a criminal charge. You know, she got pulled over with her child in the car. She was charged with a DUI and child neglect for having the child in there in the car with her. But then she also had a CPS case open up because she was being unsafe with her child. And so she could have gone to the drug treatment court for her criminal charge, but the judge allowed her to use family treatment court as instead, because there's a CPS model. But the vast majority of our cases, there's no criminal charges pending. There's CPS cases that would regularly advance through a court system to deal with their parental rights, but now can be done in family treatment court with a more, encouraging model. I hope that makes sense.
And just to back up, Susan, CPS
Thank you.
cases are civil court, and they're still overheard, or they're still seen by circuit court judges, but it's a civil case versus a criminal case that is also overseen by the circuit court judge. So I don't know if that helps.
Thank you, Amanda. Yeah, so if you're not familiar with how abuse and neglect cases work, there can be criminal charges of abuse and neglect, but most of our cases with CPS are all heard through civil court. So your circuit court judge is listening to those cases in the civil hearing.
Thank you.
Sue, that's all I have. I'm turning it over to you.
No, I think that was great. It was good discussion at the end, just for clarifying questions, a good chance to be able to ask questions. Any other questions anybody want to put in the chat or bring to the group as a whole? Okay, well, thank you for joining us. You will be receiving the evaluations either this evening or in the morning if you want to complete those. And if you need, certificates for your CEUs, we'll work on getting those out to you. Please don't forget, if you want to submit questions or cases, our next session will be our last one for this cohort. So we hope that you're able to join us for that last session. If you have any questions, you can always reach out to Melina, Leslie, or I. We'd be happy to help you. So thanks for joining us today and hope you have a good evening.